Um, Thank you very much. First of all, I would like also to congratulate the organizing committee, Dr. Sparias, Dr. Patakos, for this continuation in providing education to all of us through this meeting. And I'm going to start to give a little background and then go to the case. So the tricuspid regurgitation challenges are here. We know that the mortality increases and the outcomes with medical therapy are not as good as we expected. Well, I think we start to realize that actually, and according to the data that I see here on some publications, the heart failure with reduced CF and atrial fibrillation might be better than having preserved EF. We see here the data and we see that actually it's getting worse with the tricuspid in this situation. Also, the atrial function related to regurgitation does not have a good prognosis, maybe some also difficulties treating that percutaneously. Usually, so we have to recognize the prevalence of TR, which is very high, and also that it is an independent predictor of worse outcome. It's an heterogeneous entity, and with the preserved EF and the atrial the regurgitation tricuspid, things are actually not as very promising as we know. There's a different categorical classification of whether it's ventricular, atrial, or device-induced regurgitation or primary TR. And tricuspid valve has some unique characteristics: dense chordae, thin and variable leaflets, and the annulus is dilating towards like a D-shape or forming valve. And we have some good modalities to look at the valve when we're trying to correct it percutaneously. Of course, fluoroscopic is the most used, as we see here, and we see how it looks on the fluoro. The most important, although, tool is the transesophageal echo. There are several steps when you do the procedure, and definitely when you have a good anatomy, your chances, previous speakers actually pointed up very well, you have more possibilities to have a good results. Small septal lateral gap, less than 7 millimeter, anteroseptal gap, confined prolapse, and tri-leaflet morphology. We wish to have these patients, Dr. Sparias, but they don't usually come like this. And so what we need to do with the tricuspid H2H repair, we need to have an optimal imaging. We have some tips and tricks that we need to follow, how to avoid the single leaflet device attachment, evaluate for a second device, and of course the 3D might be helpful. The three views that we need to do is, as we see here, during the procedure. Here we see the transgastric, we see the septal leaflet on the right, we see the lateral, anterior, we see the posterior, there are two posterior leaflets. The transgastric view, as we see here, is very helpful to define the anatomy and also guide the procedure. We do the transgastric also to be able to do the grasping, as you see here, and now we have this fusion type of imaging, which we don't have it, but in our practice, in our institution at least, but this is something that might be helpful during the procedure. When you cannot do the procedure, some tips, of course, you can do opposite of Trendelenburg. You can put a pillow on the right shoulder, try to get better imaging, and definitely you want to avoid the side bites because this is an unstable, I would say, isolation of the leaflets. And the better you see, of course, like here, on the right side, the better chances are that you're going to capture, and you can verify this. Here you can see that your leaflet, the anterior, is not engaged well. This is better engaged. And when you're done with one clip, you have to reevaluate things, see if there is a residual leak, and if you have to use it a second clip. The PASCAL has some unique characteristics, which I prefer for the tricuspid valve. There is relatively traumatic grasping with the PASCAL device. You have the ability by moving with the nitinol, the system, not to put a lot of tension. Second, you have the ability, despite the dense chordae which lies beneath the tricuspid valve to elongate the device, and in that case, like we see here, to avoid being stuck down the valve, which is a very, I would say, discomfort situation. You have the independent grasping, which, of course, a lot of devices have it, and this is something that helps you to optimize your results, and this is very important. As we see here, this is not a theoretical concept, because on this experimental in animal studies, in the cadaver animal studies, we see that if you do a control with 2 bites, 2 times putting the PASCAL on the tricuspid versus or the mitral versus 15 clasps, still you do not go above the threshold that you see here, the dotted line, which is the threshold for determining that you have a damage performed in the surface of the valve, on the leaflets. So we have any now, let's say we have any clinical data to support this use? Yes, we do have. We have the PACE registry and the TriClasp registry, both registries, excellent results. The PACE registry is anyone who is coming, you know, in a European study, in a European registry, was involved. We have about more than 1,000 patients with high risk. We have severe TR, the severity at 96%, complex anatomy as we see here on the right. And despite this, we have a very good result in reduction in the severity and a reduction in New York Heart Association. Of course, as you see, they are not 100%, they are not 95%, because there are limitations, as we'll see. The more experience we have, here it looks like from that study, the finding that if you do more than 21 cases, if you have done actually more than 21 cases, then the chances that you get the better results are more than if you have less experience. So in conclusion, it's a good modality and a technique to try to reduce the tricuspid regurgitation. It reconfirmed with the TriClasp study also, again using the PASCAL, population more than 300 patients against registry, good result. Reduction, as you see here, it's not, again, 90%, but at least we have a significant, as you see on the Greek, reduction up to 1 year follow-up, and this is mild to moderate to 87%. And this actually is resulting in less hospitalizations and combined heart failure and hospitalizations, better results, and improvements in functional and quality of life, as we know from the other trials that have been published. The class 2 TR, this is a randomized trial comparing to PASCAL versus optimal medical therapy, and we have a population which is sick population, as we see here, and we have the ability to implant the device with a relatively short, but not, I would say, minimal period of the procedure, 148 minutes. And we have very small numbers of SCLDA, 5.8%. But overall, there is an improvement in the reduction of the TR and also in the quality of life. And also there is an independent index, RV function that seems to be improved, like the RV of stroke volume, the dimensions. So we have documentation that we have, and we can use this device to provide better outcome in our patients. Not ideal, but better outcome for sure. And less hospitalization also. This is a case that I'm going to present, very complicated, I would say. It's not just a tri-clip or a PASCAL device that we put in a tricuspid valve. It's a case where we have a patient with multivalvular disease, difficult patient, 83 years old, with a previous CVA, some difficulty aspiration pneumonia from time to time. He came with heart failure, pulmonary edema, and I see here a lot of, like you see here, diabetes, chronic kidney disease, and all these other comorbidities. We did the baseline evaluation, that was a long time ago, and we see that there is some TR, 2 to 3 plus, but also there is this degenerative type on both actually sides of the heart, involvement on the mitral, on the bottom right, you see here it's everywhere. So the patient was, of course, refused by all the surgeons, 80 so much years old with a stroke. So we decided to proceed with first with the mitral, see the results, see what happens to the TR, hopefully to get less and not to have to do anything on this patient more than what with the mitral. The first procedure, as expected, was more than one case, one clip. That's a mitral clip, actually. And the final results, which explain this one, here was the initial. Here was this smoke. Was relatively good. We're satisfied with, and then 6 months later, he comes back with again everything opening, as we see here, and there's a leak both on between the two devices and also in the medial side. So of course, again, 6 months after, the decision was to try to fix it. Obviously, there was some tear or whatever happened on the leaflet. This is a degenerative valve. This can happen, and due to high risk, again, we have to try to put a clip where we started, try to put a medial the device where we expected to. You can see actually the mobility of the device that led to the significant mitral regurgitation, and we put the device in the medial, and then. A few minutes later, we put the device. Again, the tissue was very fragile. We do have, again, more than the immediate initial result. So that the question was at the time what to do. There is a fragile tissue. So we decided, although it was very hard and difficult to go with, in order to stabilize this device, to go and put another between actually the two. And actually, this is the procedure. You can see the mobility. At least, you know, by putting that device, we stabilize this and this in a very mobile valve. And yes, we managed at the end to have a good result. So this is the result of the mitral. And we thought, okay, we have finished with the patient. Hopefully, he's not going to come back. But after 1 year, he came back with edema on the lower extremities and right heart failure, actually. So we decided, the family decided, actually, and insisted to proceed. So we proceed now with thinking all these advantages of the PASCAL. We proceed with the PASCAL device, an ACE device, and I actually pointed out the benefits of the PASCAL in this situation of the tricuspid valve. So we put the first PASCAL, as we see here, and the second PASCAL was the device here, and we have, as we see here, the procedure. And this is the final result for the tricuspid with a very, I would say, satisfactory. And looking also, let's see, okay, and this is the final result. So in conclusion, we report a successful case of redo both tricuspid, mitral, but also needed the tricuspid. And I think this is a very uncomfortable, but at the same time, the only solution situation in several patients that they have entered this high-risk age and a lot of comorbidities. So this is the end. Thank you very much.
Thank you very much, Professor Vavuranakis, for your excellent talk and your case. How many clips finally?
1, 2, 3, 4, 5, 6. Different clips, although they are not the same.
Very good results, you know. And,
XT, NT, PASCAL.
Congratulations, you know, for your efforts for this.
He's doing well. He's actually back in his home. Or no, he's not very, you know, walking around the city, but he's surviving well.
Would you consider to do a atrial fibrillation ablation as well in this patient?
For the atrial fibrillation?
Yes.
I mean, at that time, you know, with this severe MR and the functional and the anatomical changes on the atrium, it would be something that would be unfavorable anyway to do the...
Exactly. Dr. Spagis, any comments?
Well, it's an excellent result. I think this case demonstrates all the difficulties that we have to face in these cases that many times are very complex, like this one. So that was like a Barlow's mitral valve.
Yeah, Barlow.
And you had a very good initial result, but there is remodeling of the leaflets. So in the follow-up, we see that, especially the first 6 months, because after 6 months, you have a good scarring.
Tissue, yes.
Yeah. So, yes, Dr. Patakos, so you had the relapse, and you try it with another device, as everybody would do immediately. You had the SLDA, and then the other option would be to go between. You had a very acceptable result, and this shows how you should persevere in these cases and not give up. Try to get a very good result on the table and not be disappointed if something goes wrong. Keep trying to get the patient stable off the table. And then for the tricuspid valve, as you said, PASCAL makes easier, and you also had a very good result. So sometimes we do procedures together, and some others we wait for the tricuspid valve in the hope that it will get better after a few months. Obviously, in this case, because the mitral valve procedure was so complex with multiple devices, even if I wanted to do the tricuspid on the same day, it would be a very long day, so I would leave it later on. From your experience, how many of the cases you've done a mitral procedure, and they also have a significant or at least moderate TR, they come back with better, with the reduction of the TR regurgitation?
Kostas, if it is, you know very well, if it's a functional, it will improve. It's a functional. If you have a severe MR, the valve does not look bad on the tricuspid, the leaflets are okay, but there is some, you know, regurgitation, moderate, not torrential or something like this. And actually, we had some cases, like 3 or 4 cases where we do the mitral, and it improved significantly, so recently actually. So, and that's what the guidelines do it, but I think as an experienced operation, you have a feeling which one to expect to improve. And the other thing is, like we said, the tricuspid is a forgiving, you know, even if you have a little moderate MR or, you know, you can wait and then decide. So I don't feel like an urgency to do it because something might get better. The other thing is sometimes those patients, like this patient, the most problem was not the procedure, which was, of course, like you said, time-consuming, disappointing. It is that afterwards, when he went up on the unit, at least for 1 day, and then on the floor, he started to develop because of the stroke, aspiration pneumonia. So we have like a prolonged hospitalization with fever. You didn't know what would, you know. So this is, I think, it's better not to mix several procedures together. That's my impression.
Thank you, Professor Vavuranakis, for the excellent presentations. I would like to ask you, from your experience, how often is to see more than 3 leaflets in the tricuspid valve, and if it does affect your plan for the procedure? And the second is there any value of pulmonary hypertension, systolic pressure of pulmonary artery, a cutoff that you must avoid to implant a TriClip?
Well, you know, classically, if you are up to 70s, I mean, this is a problem here because you have severe pulmonary vascular resistance. It's going to improve unless you do your mitral, recheck with the right heart catheterization and see that everything has improved. So you have to document if you go on the high. And TriLuminate also have an exclusion with 70, if I remember well, 65 to 70%. So I think you should do the mitral, reevaluate the patient, and decide whether you actually you should do or you can't do the procedure. So more than 3+ procedure as from the beginning?
No, I mean, how often is to find more than 3 leaflets of the tricuspid valve?
Oh, you do. Especially on the posterior costas, I don't know, maybe, quite often we see P1, P2 leaflets. Yes, it's not very rare. But you decide which one to go, you know, of course. So
the most usually P1 and P2?
P1, P2 are those that there are usually 2. I don't see, and occasionally the lateral, okay, you can see, septal is septal, you know, it's usually, the problem is you have to have a good septal, like Kostas, I think they have this case where actually it was, the septal was good, but it was tethered around the one they presented.
Dr. Patagos?
Another brief question, just to see how generous is our government, cardiac surgery and cardiology. We repeatedly ask for 1,000 addition to our budget for a cardiac surgery, which, just to your knowledge, is between 6,000 to 8,000 euros. So the whole operation is 6,000 to 8,000, and we're asking for another 1,000 to alleviate a little the patient's burden. How much is the budget? How much is the cost of the 6 clips to the tricuspid valve?
Well, the clips are provided to the extra one without any cost. What is cost?
Just how much this costs.
No,
I don't care who pays those. What is the budget? What is the cost?
the cost is for what we pay, not what the company has spent. The cost is one clip. But the guiding catheters are charged. For example, if you used 4 guiding catheters, it will be extremely high. But in this case, for the clip, you use the same catheter. You don't use another one. So I don't know how much total is like, I don't know how much we'll charge for the clip one, but whatever you charge for one clip will be charged for the second clip, for the third.
It's per procedure. It's not per clip. It's per procedure. It's approximately the same with TAVI.
Same TAVI, yeah, it's not different. Yeah, it's not an issue of cost if you put 2 or 3 or 4 clips. Clearly this. If you put 2 or 3 TAVIs, it is a problem, because then you pay for the new device again. That's a difference. No, it's provided.
Okay, no other questions. All right, let's move